The people that you work with are very important, hearing their voices, because again, they're at the front line. So without their input and without taking into consideration how they feel, you can just tell people what to say and how to act. They have skin in the game and they're really smart and they're really very in tune with the patients even more than the doctors. So we need to be very supportive of our staff, meet our staff where they are and listen to them when they have opinions, bring them into the fold actively.
But what about the staff? What about the nurses, the medical assistants, the administrators, the financial counselors, the advanced practice providers? Someone has their back. Dr. Debbra Keegan is both a full-time REI in New Jersey and Staten Island. She has been for 18 years. And she's CCRM's Vice President of Clinical Partnerships and Strategy. Dr. Keegan offers how these three different groups can support their staff. 1, physicians. 2, leadership teams. 3, the staff themselves. I talk about how Mendel's Clinical Pharmacy is known for supporting staff with their crazy high 96 net promoter score. Several nurses have told me how helpful Mendel's is to them. And Dr. Keegan shares some of the solutions she's vetting or has implemented at CCRM. 1, a new patient navigator system at their New Jersey office and how they implemented that new patient navigator system. 2, the introduction on every new patient visit to mental health resources. And 3, a hint into what might be coming with wearables and other monitoring systems based on research Dr. Keegan has been reading about sleep, the vaginal microbiome, physical activity, metabolism, and other wellness fundamentals. If you enjoy this conversation, please let Dr. Keegan know and consider giving us a review on your podcast platform. Enjoy. If you like the information in this episode, we're compiling so much more data on new technology in IVF, products, services, market analyses, info on mergers and acquisitions, and data on every company in the fertility space. Go to data.insidereproductivehealth.com. If your company isn't an IVF Heroes Universe sponsor, your competitors are so much more visible to your customers because we report on your category and we give that info to your customers. Go to data.insidereproductivehealth.com to learn more about other fertility companies or submit your company today. Don't be left out.
Today's advertiser helped make the production and delivery of this episode possible for free to you. But the themes expressed by the guests do not necessarily reflect the views of Inside Reproductive Health, nor of the advertiser. The advertiser does not have editorial control over the content of this episode, and the guest's appearance is not an endorsement of the advertiser.
Dr. Keegan, Deb, welcome back to the Inside Reproductive Health podcast.
Thank you, Griff.
How would you describe the challenges that your staff are facing today?
Patients come in and they have a lot of questions that they are picking up from their research on the internet before they even get through the door. They are very overwhelmed with sorting out the information. That overwhelms the staff because I don't think that they are necessarily prepared right away to face the patients with these detailed questions that they come in with. And then they sort of have to figure out, where am I going to get the answer for this? They're then coming to the doctor who's busy, seeing all of the patients or in the OR and doing their thing. And they're dealing with patients that are getting, increasingly frustrated because staff can't provide a go-to or a clear answer because they're trying to assimilate so much information that may or may not be true or vetted out there on the internet. They're coming in with their Gemini prescriptions and Claude. And I think that information flood is overwhelming, the clinical staff. That's for sure. I think that for the front staff, front office and administrators, scheduling is still kind of difficult. And I think it can be difficult to streamline because, you can do automated scheduling, but schedules change. And then you have to sort of go back and they have to go and chase down patients that maybe put themselves in a slot through some online platform, but that slot no longer exists because it doesn't catch up. So there's that. And then the third part are the financial counselors and coordinators. It is getting, particularly in a mandated state, exceedingly difficult to sometimes get a clear answer on what the coverage, is for the patient. The patient gets a different answer from HR. We get an answer from the person that happens to pick up the phone on the other side. And it becomes very, very murky of what the actual coverage is and bills and finances and stuff like that. So I think altogether, as the staff is dealing with a patient who, is focusing on a communication experience, but with different types of ways of communicating, multiple, it's not just telephone anymore, that can get, very confusing. I think the emotional and psychological, the stress that they come in with, and they want to get their answers, but with all of this information. And, a lot of us, we have to keep up with what do we want to convey as accurate to the patient, but we're not training our clinical staff to do that. We're not there, right? Because it's so busy. And the financial. Those are three things that I would say we're being challenged with daily from, the patients to the staff. And then the staff burnout.
I want to dig into those things, but we're not going to let doctors off the hook. Deb, what do you think doctors might be, not you, of course, not your friends, but some other doctors elsewhere, what are they doing that might be adding work to their staff or confusion or making things unnecessarily complicated that staff then have to pick up the brunt of?
So leadership is very important, right? And setting an example of professionalism and being on time and being consistent, that's a given. The next thing is, you do shared decision making with your patients. I believe, and I've had the same nurse, in my practice for 17 years. And I'll brag and say I have the longest running relationship just ahead of Stephanie Thompson, right? With, my nurse, because we've built the practice together and we take care of the patients together. And, Jen, how do you feel about this today? How do you feel about how we approach this? What do you think about this problem? We problem solve together. The people that you work with are very important, hearing their voices, because again, they're at the front line. So without their input and without taking into consideration how they feel, you can just tell people what to say and how to act. They have skin in the game and they're really smart and they're really very in tune with the patients even more than the doctors. So we need to be very supportive of our staff, meet our staff where they are and listen to them when they have opinions. Bring them into the fold actively. Don't wait till there's, a problem, but have a relationship with your nurses, with your finance coordinators, with your front desk. Be the person that walks through the door and you see a tissue on the floor, pick it up and put it in the garbage, right? Like altogether, the team culture is really, really important. And everybody on that team, their voice and their opinion, they have a different role. It matters.
You don't mean like you round with your staff, do you?
We have our huddles. But, I'm not rounding in the hospital anymore, right? So when I go through my patients for the day, my nurses are in a constant huddle essentially, but we'll go through, the patients that are tracking to treatment or when we're, getting their other consults that they need, whether it's cardiology or maternal fetal medicine. But we do, the traditional rounding is done on a daily basis. Yes, it is.
Can you think of an example recently where you asked your nurse, how would you approach this? And it was something you might not have thought of, or maybe it was a direction you wouldn't have gone, but ended up being the right answer. Can you think of any recent examples?
Yeah, actually, there was a patient that it was, again, like sort of based on technology. And when a result actually made it was a result that I would have wanted to give this patient sooner than I did. But because, my nurse had been working with her and, and sometimes we miss things, right? There'll be a delay. And in conveying information that is important, we together came with the approach, like obviously transparency, number one, but where sort of what are we going to do for her to make the next step in this decision easier? Because it's, we've had this delay. And together we pulled the levers that we needed to for this team over here to do this and this over here to do that. And largely these are things like, and I've talked to you about this on this podcast, like fielding the genetic testing results, right? And having to then navigate for patients what even the genetic counselor said. We're in the middle of, of working that pre and post PGT testing at CCRM that is buttoned up, in terms of like the genetic counselors we have available and who, the patient might need to talk to if they don't understand it from the physician. Getting the nurse's take on how much that patient might understand from her perspective or where they are emotionally just helps you deliver the information to someone in a way that they can handle it and accept it, right? So if you're thinking of more concrete things like scheduling, I have a patient who was going to, the plan was for anesthesia transfer, but because of my schedule, her schedule, and the anesthesiologist's schedule, it was either going to be a different doctor or it was, going to be me with a different approach, for her comfort during the transfer. Just a very difficult transfer overall. And, nursing and I like solved it together. Instead of me saying, how could you screw this up? Right? Like, how could this be? And it's everybody else's fault, whether it's scheduling or anesthesia or the nurse. It was, okay, well, we could solve the problem like this together. And you call the patient and she was perfectly, happy with the 3 choices that we gave her for how to solve that problem, that it wasn't going to be exactly what she expected. And so, when you do that together, well, the right people are involved. The patient also feels like there are multiple people looking out for her. And that's, we want the patient to feel that together, the team is really just trying to support them through this, get them to the outcome that they desire and with the best experience, for them. They have to trust us. And I can't do the job alone. And I let, the patients see that. The way we, establishing expectations, right? You may not see me in your follow-up. You may see, our nurse practitioner. I talk about our nurse practitioner. I talk about her personality and how well qualified she is. And that overall together, we're looking after this, this patient's evaluation and the planning and the experience together. So I think, if the patient is aware of that too, and if you look at, a lot of the reviews that we get in the Princeton and Staten Island office, it's about the team. It's not often just about the doctor or, just about the nurse. It's about the team. And it's like family. And I think if you think about the warm and fuzzy feeling when you're, with all of your family on Thanksgiving, it's kind of the way we want patients to feel as they're going through this.
Most patients don't drop out of care because of medicine. They drop out because of confusion, cost, silence. When patients feel supported, informed, and in control and have access to experienced pharmacy professionals, they stay in treatment longer and abandonment rates drop. That's why fertility clinics partner with Mendel's Clinical Pharmacy. Their pharmacists deliver education, access, and real human support so patients actually understand their medications and what comes next. Add lower out-of-pocket costs through the Fertility Instant Savings Program, and staying in cycle gets easier. With a 4.8 star rating and a 96 net promoter score, that's insane. Patients trust Mendel's. Visit mendelspharmacy.com to see how they support teams like yours, or reach out to me and I'll be happy to make an intro. That's mymendelsPharmacy.com. For things like financial counselors, Deb, where you mentioned there's so much now complication because of different insurance and now having these employer carve-outs, there's all this pre-auth that needs to be done at different stages, etc. How much in a position are you as a physician to even be able to support your staff? Like, is that just something outside of your domain that they have to struggle with? Like, can the doc really support them in meaningful ways in that regard?
Well, no, I think it is just getting back to that leadership and establishing relationships and recognizing that, the people that are spending 45 minutes on the phone for one answer during the day, they're also going to have, short fuses sometimes and feel frustrated. So whether it's as easy, Griffin, as, saying hello. How are the kids? How are your grandchildren? And just really being interested in them as people, because that work is thankless. It really is what they're doing. I think, getting back to the huddle, helping them when we were supporting them on the work site, helping them understand the priorities, right? Who needs to get cleared first, prioritizing what they need to be doing. And they have to be very familiar with, this one takes 7 days. This one takes 21 days. So we look at those lists and we help them prioritize that. But a lot of times it's actually that in that one, it's supporting the human, and it's actually too helping them with the documentation they need sometimes for those authorizations, right? So they may ask for a letter, or they may ask for something in the records that they can't find, that the clinical care assistant or the nurse will have to help work with them to pull out, to, set up that very clear picture of what we are asking for and why. And even then, when we don't get the authorizations and we need to set up peer-to-peer reviews, or we need to set up appeals, it's just important for us to respond to their requests so that they can set these things up without, too much delay.
Those are things that your average REI can do, but you're not your average REI, Deb. I think you got a promotion since you and I last spoke, if I'm not mistaken. The CCRM network level, you're VP of Clinical Partnerships and Strategy now. Is that the case?
That's what they say.
So that means that you are maybe vetting some solutions or helping to implement solutions at network-wide. Does that include things that have to do with prior auth and that sort of the administrative side, or are you mostly focused on clinical solutions?
It does. I'm mostly clinical, but I think when it comes to patient experience, that does come into play, right? I don't, the business side of that, I don't have the ability. I'm still full-time practicing physician as well. So my practice hasn't, contracted in any way with this role. And I think that's important, because I think that, credibility and, reliability in being one of the docs is really important, right? Sharing that experience of being, in the trenches, seeing the patients and being with staff just, actually gives me some relevance in this, in the grand scheme of things with the network. So I might hear very high level about how it would work for the patient, but to your point, we're trying to put those things together that address each of the, each of the things that we can identify for why patients drop out or what creates their experience. And certainly, coming in with it before you even sit down with the doc, an understanding of what your insurance covers, I think is very helpful when we're framing a discussion about options. I just did it before getting on with you. I have a patient who no doubt will benefit from IVF treatment, but her insurance is, in New Jersey, lesser before greater. So she needs to do IUIs before she moves on to IVF. And the fact that she knew that, when I told her that, this is how we were going to approach the case, she was ready for that. There were no questions about, why can't I do IVF? I mean, it's just, if you have that ability and you want to pay out of pocket, great. If we're following your insurance, then this is, how we have to do it. So when they come in armed with that, there are no surprises. It's one less stressor. So there are, companies and platforms out there that will vet that insurance for you ahead of time. And then the patients have some understanding of what they're starting with. Our financial coordinators and counselors then, once we design the treatment, we'll then go get those authorizations, those pre-authorizations, have a conversation with the patient about their out-of-pocket expenses. And so as they come in, they hopefully understand what their insurance covers or not. And then as they exit, they understand what they're responsible for with their treatment. And in the middle, we can counsel them appropriately, knowing what, restrictions they may be facing with coverage.
What's one operational improvement that you've made in your regime as VP of Clinical Partnerships and Strategy? Or if you're still vetting it, what's one that you're looking at?
As for operational, I think that a patient navigator is probably the one that sticks out, in my mind. the education and care coordination and, the emotional support. And, there are platforms that help with that very thing. And I think that if there's that constant, ability or opportunity to communicate with someone about what do I do next, or this is how I'm feeling about this, or my shot leaked and what do I do? The injection leaked. I think that helps pull together all of these areas where patients are finding it really difficult to get through their treatment, to get to the end of to cross the finish line. And if they have that input, I think that can be incredibly impactful to keep patients engaged. So there's that. Then there's also the introduction with every visit that we understand that there's emotional and psychological impact associated with this process. And again, right off the bat, these are our mental health offerings, partners. This is, a resource that we have where we can go if at any time you need to speak to someone because you're feeling like, you need someone to talk to outside of the clinic. So we do that, right at the beginning. So again, those two things coming into the patient experience. And then the third thing that I think will be very impactful is something I mentioned earlier. Where can we go? If you just take the very simple euploid transfer doesn't work, and it doesn't work multiple times. And we've done the uterine investigation and we've done the male factor investigation. What is the next frontier? What are we missing about the patient? And I'll take the embryo in the lab out of it because we're pretty good at that, right? Understanding what that is. And the people that are looking at optimizing health in ways we haven't done yet, I think is going to be very impactful for the patient. There is some data out there, and we'll talk about this another time, that, addressing certain deficiencies, whether they're, lifestyle, behavioral changes, are the hardest thing for a patient to do. I think we can talk about it, but, we're not out there working out with them on the daily. But I think uncovering some of these things that we haven't yet gotten to that are not lab related or embryo related, that are not the uterus, is going to be very exciting.
Yeah, and this third factor, we will have to talk about at a different time because I need to prepare more, because I'm not a clinician, so I need to do more homework, but so that I can prepare for our sequel. When you talk about things like lifestyle changes, are you talking about things like microplastics? Are you down that route, or are you talking about things like, with regard to euploid factor, are you talking about things like whole genome sequencing of the embryo? Tell me what this whole area is going to look like.
There's a few things going on out there. There are companies that are looking at, your genes and how you metabolize certain substances, right? And what are those downstream then, end products and byproducts, and how does that affect your fertility? And how does normalizing, levels of different, again, minerals, vitamins, nutrients, call them whatever you want right now, like very, very specific, but does optimizing that based on population data, based on, science and research and what we know about metabolism by supplementation, for instance, does that help move the needle on these cases that we can't really, crack sometimes? There's that. I don't think there's any question. Then there's things too, like the vaginal microbiome. A lot of patients are asking about that. There's a lot of interesting work being done on that. Would love to come and talk about that another time, with some of those visionaries and have a conversation about how that might help us in clinical practice. But the one thing, to me, physical activity is so important, and it's just so hard for people to fit in or to get motivated to do it. And it's not just for reproductive health, right? It's for general health. When I was a resident, I had a mentor that said, everybody looks at the reproductive system and sort of puts it in its own category, but it's the same system that your heart is in, that your kidneys are in, that your lungs are in. And we have to treat it as such. Like, you have to look at it as it needs to be taken care of, just like your heart. And it's the same stuff, right? It's eating well, it's exercising, it's paying attention to, your stress levels and how can you manage those. The interesting thing, I'd love to find someone and have a conversation about sleep one of these days, because I was just saying to some colleagues last night, we tell patients like sleep hygiene is very important. Wearables, that's another thing we should talk about one of these days. What is happening in that area of the world with the wearables, and what information we're getting from that on how people's bodies are responding to, just challenges in general, whether they're environmental or systemic. But there's a ton of data out there that sleep is incredibly important. But if you can't sleep, you just can't sleep. Like, there's a lot of people that sleep hygiene out there, like, we got to figure that out too. I mean, yes, it's restorative, but I have friends that just, don't sleep. I am blessed. I sleep, but how do you tell a patient you just have to sleep? Like, I don't know. And so I'd love to get into that.
I think that it's so many levels with regard to sleep that people actually need to be taught to sleep. Many people do, I should say. How could many people need to be taught to do something that is a biological requisite that should be an evolutionary instinct? Well, because we didn't have artificial light and all of these other variables for the first several 100,000 years of human evolution and the millions of pre-human evolution that came before that. And so many of us need to learn how to adapt to sleep in this world. And so these things that you're talking about with regard to physical activity, with regard to sleep, with regard to how metabolizing different minerals and nutrients, especially with regard to that last point, metabolizing different certain substances. Is this just something that you're noticing in your own patients, Deb, that you're cluing in on, or has there been some new research recently that you've been paying attention to?
Both, because biologically, it's plausible, right? Just cellular metabolism in general and molecular biology and downstream effects of gene interactions. All of those things are going to have, be affected by environmental factors as well. So like you talk about microplastics, for instance, I mean, sure, that can't be good, right? It's just sort of obvious. So what can you do? That one is simple, right? Use glass and don't put stuff in the microwave that's going to melt and leach, and don't drink things out of plastic bottles that are melting in your back seat. We can say all of that. Getting people to affect the change is very difficult, right? There's definitely some fun stuff out there. And we'll talk about that, because we should probably get some people on this podcast to talk a little bit more about that research and where that is going. What I'm noticing in my patients, really all the time, and this really hasn't changed, is like you said, it's just evolutionarily, like, we used to be more active, right? And now here we are. We have electric cars. You don't even have to drive your car anymore, because your car can self-drive. You don't have to walk. Somebody said recently, remember when we used to have to go to the store for garbage bags? Like, now you could just get them to get delivered to your front door. So the change in the amount of activity, where people are very comfortable working at home, never leaving the house, not interacting. Social interaction is so important, right? We didn't even hit that one. But that ties into staff and patient experience, because it is a social interaction. And maybe where patients are feeling lost sometimes is that we're seeing, a little bit of the erosion of what human social interaction is in general and in the clinic. It's quite possible. So I think it's important for, us to be together. We're in the business of medicine. I think people, there's something about human touch, right? And whether that's physical touch or looking at somebody in the eyes and saying, how are you today? And I can see that you're feeling upset or you're not yourself. These things are so important. And so it's motivating too, right? What motivates me to get up and go exercise? Seeing my friends, like at the studios. So I think there's some areas we can work on there. But I do find, Griff, that it starts like where you're sitting. I think it's hard to like tell everybody, you gotta sleep better. Y'all need more social interaction. People should volunteer to not work from home. I don't think it's going that way. You should get up and go to the grocery store, go to Target and get your garbage bags, and not call Amazon and sit home and scroll on Instagram or TikTok.
So are what you hinting at, these different components that are the basic tenets of wellness, we all generally know what they are, but to your point, it's very hard for some people just to execute on. It's very hard for some people to build workout into their routine, to eat the right things, to get the right sleep. Is what you're hinting at and maybe this is what you mean by we need to have a whole episode about wearables, but are you hinting at some sort of technological bridge between the delivery of fertility care and the monitoring of those different wellness components, and using that technology and that monitoring and that data in IVF protocols?
Maybe not so much in IVF protocols. If you get that information and you have some data to back that the information, say you're getting from a wearable or from how you're, metabolizing some nutrient or something like that or not, does a person need data? Is it more actionable? Will you do something if you see something that says, look what I found? If you don't do anything, you have a much, less chance of succeeding. The protocols, another podcast, right? I've been at this for over 20 years and I haven't seen that much change in that. And, aside from some things that have crept in but mostly, right, gonadotropins, get to retrieval. That's like the basic. The rest of it is what, is what's really exciting to me. How do you improve the performance of the cycle, right? How do you get your protocol? So if you're asking like, is AI going to be able to say, you're going to type in, Deb Keegan's age, her experience, like her, gynecologic experience, menstrual experience, pain with periods, endometriosis, maybe not. You type in all those variables and will it tell me what the best approach is? You bet it's gonna. And it can. It's out there. So that's great because you then as the doctor get to look at it and say it makes sense or it doesn't and why, right? AI makes mistakes. But I do think that the assimilation of that information for us is very helpful. That's one part. Then the optimizing the patient is the other part. And it's so funny because we started with like staff challenges and we ended up here. This is why I love talking to you. The optimizing the patient, really what we need to do is back that up into, education, whether it's in high school. I have, a high school daughter. I have a college daughter. They don't get any of this. They don't get what I once said to our chief administrative officer, preventative reproductive medicine, right? It's different from all the other stuff out there. What I'm talking about is we want to do the things that are good for our heart. We want to do the things that are good for our brain. We should also keep in mind, we should do the things that are good for our reproductive systems. And that's kind of whether you want to have kids or not, right? Ultimately. But what are those things? And then it comes back to the very basic human wellness principles, right? And that works for your brain and it works for your heart and it works for your reproductive system. And we're losing sight of that. Like when patients come and sit down in my office, like they will today, they're past that. It's too late, right? But if all along we can somehow get people understanding that their reproductive lifespans are limited, that they need to ask questions about symptoms, that they need to not be dismissed. A lot of patients will say they were told it happened yesterday. It's just normal. It's just normal. I'm talking about a woman with severe endometriosis and fibroids being told for years and years, don't have another surgery, just go on the pill. Now here she is at 33 and we have to start all over because she was dismissed and she started crying in my office because she said she was talking about me and the MIG surgeon that we're working with. She's like, I just can't believe in all these years I've never had, two physicians that actually care so much about like how I feel and what I need and what I'm doing. Like, and I thought this is really sad. But for people like me and this other doc that I'm working with, it's why we do this, to really again, that the human element and taking care of people and trying to make it better. So that education and I think, working on something with that, by the way, Griff, but getting out there. People say all the time, I didn't know. And we have to help them know. So there's a lot to do still. But I think overall, even with things we hear, people are waiting longer. Birth rate is declining. I think there's a ton of opportunity, for us, for the individuals. I once heard a talk that somebody gave, and the quote was if the world's a mess, pick up the broom and start sweeping where you are. It's a good quote, right? And so we could do that little by little. It's like my New York Knicks. They chipped away at those 29-point deficits, just play by play, and we can do the same.
And after 60 years, we have the celebration we've all been waiting for. If patients are leaving care, it's often not for the reasons you might think. When patients understand their medications, when they have somebody they can actually reach, they don't feel blindsided by cost. They are much more likely to stay in treatment. That's where Mendel's Clinical Pharmacy comes in. Their pharmacists lead with education and real human support, so patients feel confident in every step. When you add in lower out-of-pocket costs through the Fertility Instant Savings Program, you would reduce drop-off risk. Then consider a 4.8 Google star rating and a 96 Net Promoter Score. That means patients trust this place. Visit mendelspharmacy.com to see how they support teams like yours, or you can ask me for an intro. I'll be happy to make one. That's mymendelsPharmacy.com. It may have sounded like a little bit of a detour to the audience talking about these patient challenges and the solutions that you're considering that are going to come into treatment, but I think it very much relates to staff challenges because all plays into the information overload, which all plays into how they interact with staff and the necessities and duties that are placed on staff. And that jumps back to one of the first solutions you mentioned, looking at a patient navigator, some sort of solution to help with that. Is that one that you all have implemented already, or that's something that you're looking into?
Yes, we're launching in the New Jersey program with someone that is going to help with that part. And that I think will, that education piece, right, is really important because again, if I use the example of the patients coming in with an understanding of their insurance benefits, if they come in with an understanding of what we need, what we're going to test for ahead of time, if they have a place where they can go to ask some questions that maybe my nurses don't need to, spend time on because they're busy with the patients in treatment, for instance, or something like that, I think that's going to help the staff a lot and it'll help the patients a lot.
How will you help, or how have you helped your staff to implement it? Because one of the biggest challenges that I've noticed of different patient navigator solutions in being implemented is that it's this thing that will help them with their workload, but their workload is so intense in the meantime that they don't have the bandwidth to implement it. And it's such a challenge for care teams because it's this will free up time for you, but they don't have the time to work it all in. How would you describe those challenges that your staff have had in implementing it, and how have you helped them?
We pick the team and we look at, who has the bandwidth, who has the experience, who can, handle the additional time, the creativity that it takes, right? Who are staff going to listen to downstream, right? So generally speaking, where, there needs to be nurse manager in charge and lead clinical care coordinator and our practice administrator. And that really helps, that's the high level where with those three at the top, you can figure out where you need to plug in operationally. When we start small, right? We have in New Jersey multiple offices, but we're going to do it in my office so that we have, I see patients in, 2 offices in within CCRM New Jersey. We're going to start with that team. And once that team has an experience that we can then just sort of seamlessly pass on, the next physician team will roll in. So the way we work really is by physician team. And that will enable us to essentially pilot it internally with oversight from those three, and then, have a motivated team that hopefully works out. We pass it on to the next group. We'll gate it and we'll make sure we understand what kind of time it will take to implement. I think something like that, because it really does seem like low-hanging fruit. It alleviates some of the demand on the nurses, and it will help the patient. People will be motivated to do it. So I'll let you know how that goes. That we're doing now.
You do one physician team at a time?
Sometimes two, but depending on the lift, which you bring up, we might keep it to one first, because each doctor team has 2 or 3 nurses, clinical patient care coordinators, financial coordinators, and then their administrators. So it just is a very, it's an experience that we can really monitor and figure out where the pitfalls are, because those teams work very similarly across the physicians. So
when you put a nurse manager on like that, or a coordinator, do you take off some of their caseload so that they can focus some of their time on that? Or if you have a practice admin on it, do you try to delegate some of his or other duties to someone else? And I'm kind of thinking in the same sort of concept of when somebody's got clinical hours and then they've got like research hours. Like, do you try to help them to do that, or is it just one more damn thing that they have to do?
it gets back to our early in our discussion, right? It's leadership. It's helping to prioritize. So if I'm asking them to do something, I'll do it with them. I'm doing the same. So I have, weekly one-on-ones with the practice administrator. Whenever the nurse manager, the, clinical director needs us, like I'm there. So we prioritize, and we're a big practice. So we're able to delegate things as, say, a priority. It becomes sort of goes lower on the list because we're working through that issue. There are other people that can take over. So we have a pretty good grasp on, what everybody that we're working with can do and what we can ask of them. We have very little, we retain our staff. So very little drift out of CCRM New Jersey, which I'm really excited about.
We talked about things that networks can do to support staff. We talked about things that individual REIs can do to support staff. What can staff do to help themselves? In your view, if you had the opportunity to just pull somebody aside, you notice maybe they're making life a little bit harder for themselves than it needs to be. How would you counsel some staff in order to be able to deal with what they've got and not get bogged down in it?
Time management, right? And taking breaks, prioritizing the list, coming in and seeing your coworkers. So again, everybody can really help understand what the work is that needs to be done. Asking for help, right? Don't be afraid to ask someone to make this phone call or grab that fax or call this patient if it's something that they can do that, is within the scope of their responsibility and their ability. But I think it's just surrounding yourself with people who can support you in your role. Again, getting back to the team, asking for help when needed, and really don't be afraid to not know. Like, one of my superpowers is that I will tell you I do not know all the answers. I do not have them, but I guarantee you I know where to go for them. And that, I think, is an important characteristic to have. I don't want my patients to think I know everything. I do not. But I want them to know that I'm resourceful. And I think being resourceful is very important because we are surrounded by really good resources.
Deb, you volunteered for like 12 future podcast episodes every time. Oh, we should do that. We should bring on this group and we should talk about this thing. So you're going to be back. I got my next 12 seasons planned out because of you, and I can't wait for it because I love having you on. Dr. Debbra Keegan, thanks so much for joining me again. Go to data.insidereproductivehealth.com. That's where we're compiling so much data on new technology in IVF, products and services, market analyses, info and mergers and acquisitions. Every data point that we can on the field writ large and the companies in the fertility field, we're compiling there. Go to data.insidereproductivehealth.com.
data.com as we build that over time. And if your company isn't an IVF Heroes Universe sponsorship, your competitors are getting more visibility because we report on your category and we give that to your customers. We do that multiple times per year, and we do it around big events like ASRM and ESHRE. Go to data.insidereproductivehealth.com and submit your company today. Don't be left out.
Today's advertiser helped make the production and delivery of this episode possible for free to you. But the themes expressed by the guests do not necessarily reflect the views of Inside Reproductive Health, nor of the advertiser. The advertiser does not have editorial control over the content of this episode, and the guest's appearance is not an endorsement of the advertiser. Thank you for listening to Inside Reproductive Health.